look it up in your program. I'm not going to read it all because then we don't have time for her anymore. Thank you.
Thank you, sis. Am I? Okay. Thank you. Thank you, Silken. Thank you, Bob, for thinking of me to come and give this plenary. The abstract that you see will be somewhat different from the talk I'm going to give because I literally changed the talk about 2 slides into Ellen's presentation. So you're literally seeing, like, just-in-time presentation being given to you as we speak. So I like to talk in the context of light for life. I'm in the biomedical engineering department with joint appointments, currently only in neurosurgery, only because at Vanderbilt we have a campus that brings together physics, engineering, psychology, arts and science, music, divinity, and the medical center all in a single campus. What that does is allows me easy and full access to clinical care, where I can just walk over and talk to a surgeon or a physician or do studies on patients. What that means, therefore, is that if you think about it, medicine is a problem-rich environment. There's always a problem to solve, which essentially means I have something to do for the rest of my life. But there are some problems that are more amenable to optical solutions than others. So when I talk in the context of light for life, and I need to make sure I know what's the laser, you heard stuff up here. You heard about vocal cords with multiphoton microscopy. Google is great to get images from your labs, as well as welding nerve cells. That's what you heard thus far. But there's more that you can do with light and lasers and in biomedical applications. And some of what I'm going to talk about is what's down here, which is to look for things, to identify things and detect them, and see what happens to help the surgeon do a better job. You can do a variety of different things with light interventions. You can do fundamental discovery of what's going on in the brain or other parts of the body. You can do therapeutics, which is what you just heard. You can have a laser scalpel. You can do LASIK or tumor surgery. You can also do therapy in terms of something called biostimulation or low light level therapy, where you send a small amount of light and help somebody control pain. And then you can also do what I like to do, which is diagnosis, which is detect cancer, guide surgery, and a variety of applications along those lines. All of these typically rely on lasers, but not only. They tend to be everything from using LEDs and lamps all the way to VCSELs, which is sort of the next new technology. So what I would like to do is talk a little bit about some fundamental discovery and a little bit about diagnosis. And I'll tell you why I changed my talk on the fly as we go along. So I'm going to start by talking about diagnosis. The basis for diagnosis comes in the fact that optical detection has been around since the 17th century. The microscope has been around since then, and it's pretty much used to guide what's going on in the body. If you have a mole, you go to a doctor, a dermatologist. He looks at it and uses the ABCD, which is area, border, color, and diameter, I believe, and essentially uses his eye as the detector to tell whether you have cancer or something that he needs to biopsy or not. So or you can go one step further and not just use your eye, but use a microscope to do that. When we use more sophisticated detector technologies, we're essentially doing the same thing. We're looking for things that the eye can't quite see, but essentially guide the doctors to help diagnose or detect and see what's going on. If I look at the history of lasers, and I love this slide because it puts everything in perspective, and both Towns and Shallows in there, along with a bunch of other people. A couple of people that I threw in there, little things, are Stokes and Raman, because I'm going to talk about fluorescence and Raman, and those are the guys who coined those phrases, even though the effect itself was around a long time. Something that really helped the field of biophotonics is A.J. Welch's work, where he did a lot of work in laser tissue interaction to really show what happens when lasers interact with tissue. And that's pretty much what led in the 70s to a lot of work on applying light for tissue applications. So I'll take this one step further and say, now if you think in the context of optical detection, most of the work pretty much happened after the 60s. While the individual techniques were discovered, this is all in the context of applying it to the body, okay, for biomedical applications. These are all a variety of techniques have been used. Everything from diffuse reflectance or elastic scattering all the way down to terahertz imaging. And I stopped at 2008. You can keep adding. At some point, you just go, you run out of room in your slide. There's new techniques that are coming up constantly. And all of these pretty much, so you can come up, this is a small laundry list. You're not really meant to read the whole laundry list. There are a lot of techniques that can be used for detecting things in the body. They all base itself around different interactions of light. And you can do some really interesting things with that. You can do spectroscopy, or you can do imaging. And the thing when you talk in the context of optical diagnosis then is what's the medical challenge? There are 3 or 4 different things you can do. Okay. First, you can diagnose. You have a mole that looks not quite normal. You go to the dermatologist. The dermatologist looks at it and decides whether to biopsy. He takes a biopsy because he thinks it might be suspicious for a cancer. It's taken to histology lab, and somebody looks at it under the microscope to decide whether you have cancer. You go back and you get surgery. Diagnosis is probably the most difficult problem out there. It requires you to know and recognize pretty much what is going on, the whole spectrum, any and every possible thing that you could have a mole or a lesion in your hand or somewhere else in your body for. So the primary contributor for this is going to be the changes that might occur that's associated with something like cancer. But the biggest confounder or problem is that your skin is nothing like my skin, is nothing like any one of yours. Just look next to the person next to you. None of our skin is alike. So just basic physiologic variability is a challenge. We go one step further, instead use the same idea of optical detection, but now you want to guide surgery. You want to tell the surgeon where to cut. Where does normal end and where does tumor begin? Where's that line they want to cut? The question now becomes binary. I just need to know where is tumor or where it's not, so I can tell the surgeon where to cut. Challenge is significantly simpler, but surgery usually occurs in sort of a bloody environment, so blood is a problem. Okay? Screening, which is when you just want to look at volumes of patients and see what's going on, there is still binary if you really think about what's screening. Screening requires you to identify if something is not normal. Still binary. Do you have something that is not normal so that I need to study it further or look what's going on or not? So it's also a relatively straightforward problem, although challenging because you need to look at volumes of patients in order to get to your technique. Patient variability, again, becomes an issue. I won't talk about sensing in this context just because to keep time and things moving along. So the problem is that most applications of technology are focused on technology development. So somebody comes up with a whole new technique on how that is governed by the physics and the challenge of developing that new technique. I can put A and B together and do this cool new thing that allows me to image deep. Okay? So I want to apply this to the body because that's always the gold standard, right? That's the holy grail. I want to apply this to apply for the body. I go around looking for what medical problem can I solve. Okay? That's pretty much how things work for the most part. What ends up happening is that you get stuck with the limitation of the technique because you've not necessarily picked the problem that's best suited for the technique. You've picked up the technique, that's what you have, and gone around looking for a nail with a hammer in your hand. Okay? So what I think, though, as a biomedical engineer, is that the problem ends up suffering, as in the clinical problem that I want to try to solve to help patients. So something in my lab that we do pretty much across the Biophotonics Center at Vanderbilt is we've tried to apply what I'll call the pedagogical approach to learning. If you look at curriculum anywhere around the world now, everybody's starting to do problem-based learning or case-based studies, right? So that's sort of what we implement in our lab for research. We take a clinical problem. That's what this is referred to as a star legacy cycle, by the way. Comes from this book on how people learn. You take a challenge, you really understand the challenge and get different perspectives of the challenge. You come up with techniques that might best suit to solve that problem on that challenge, research and revise and develop it, and therefore test it and go public with it. Okay? So that's the cycle we pretty much have developed. I'm going to give you one example. So my original talk had 2 examples. So I'm going to give you one example and take a tangent from there. So here's the first example. The idea here is to guide endocrine surgery. This is surgery that's happening in this part of your body, okay? The parathyroid gland, everybody knows where the thyroid is, which is right here in your neck, okay? Many of you probably know people who've undergone thyroid surgery. Behind your thyroid are 4 little glands that have the size of a grain of rice. They're called the parathyroid glands. They look like that. There's little red dots that you see right there, okay? They have a very significant role. They're that tiny, but they're the only things in your body that regulates the amount of calcium that you have in your body. You take that out accidentally, you no longer have the ability to regulate calcium. You might end up having all kinds of hypocalcemia-related problems for the rest of your life. You think, what's the big deal? Well, there can be significant consequences. Think of your bones. Think of all the things you need calcium for. All of those things start to misfunction, okay? So because it's so tiny, the most common surgery is having thyroid surgery because you have enlarged thyroid glands. You have big thyroid glands that crushes these tiny little parathyroid glands. So when you have a surgery, and you can go online and look at any of the blogs of people who've had this kind of surgery, the first question they ask is, I had this surgery, I came out, my parathyroid gland was removed, now I have this lifelong problem with calcium, can I sue my surgeon? Okay. If you look at the fine print of the consent form they signed, it says explicitly that one of the side effects of the surgery is that you could have lifelong problems with your calcium. Because it's small, the surgeons can't find it very easily, and they have trouble doing the surgery. By the way, you can have thyroid or parathyroid disease that requires one or the other to be removed. Now, if they were to remove it and they found it, they actually take it and just suture it back if it's viable, and that works too. So it doesn't have to sit there. It could sit here and regulate it, and it works just as well. So they need to know that that gland actually came out. So accidental removal is the most important thing in this whole process. So this is something we sort of, the story is that there was she is no longer a resident. There was a surgical intern who was working at Vanderbilt who had heard me present some of my other work, came to my office and said, hey, I've seen you do all these different techniques to guide surgery. Do you think we could use your technique to find the parathyroid gland? Because I see this happening. I've been observing a whole bunch of cases, and it seems like this is a big problem now in clinical care. I said, okay, well, let's see if somebody's already done this before. So remember, what they wanted to do is, this is not about finding disease, okay? This is not about cancer. This is not about any kind of disease. This is just to find the gland, anatomical guidance. So we looked in the literature. People had looked at parathyroid cancer. People had looked at thyroid cancer versus normal. Nobody had really tried to look for the organ. So we did a variety of different, so that was our challenge or our goal. I think that's my next slide. I should say that current methods, that people or scientists are always trying to see if they could come up with another way. Why do we want to come up with an optical way? People currently use ultrasound or CT, MR, or different kinds of methods. All of those methods are preoperative. All of those methods require exposure to radiation, and really more to the point, all of them rely on the fact that the parathyroid gland has to be diseased for it to work, for them to be able to find the gland. So if it's a normal gland, they can't find it, okay? So the need is to find a real-time intraoperative system that is highly accurate, that can find this gland in real time, provide feedback to the surgeon while the patient is still in the operating room and table, so that they can decide to do the surgery appropriately. If it's thyroid surgery, then they want to take out the thyroid gland and leave the parathyroid alone. If it's parathyroid surgery, they want to remove the diseased parathyroid, leaving any normal alone. So that's our goal. So we did a variety. I don't have all the slides for it. I'm just going to show you what we actually found. We actually used a variety of different optical techniques to see if there's anything unique about the parathyroid gland that would make it stand out compared to everything else that's in your neck. Think about what all is in your neck. Fat, muscle, nerves, bones, cartilage. What else is here? The thyroid gland, the parathyroid gland. So in the middle of all this, I need to find this grain of rice. Okay? Think about that. Look at the person next to you and see how thick their neck is. All right? Seriously. It tells you the challenge of what you're trying to do. Okay? We looked at a variety of different techniques that we had that we could apply reasonably and quickly in the operating room while being able to detect this that could potentially make the parathyroid gland stand out. We discovered, and this is what's not, static slides just don't show. So we looked at UV visible fluorescence because that's usually what you do. Biological fluorescence is usually in the ultraviolet and visible range. We looked at diffuse reflectance or light scattering, which is again, usually you look at about up to 700 nanometer range in the UV visible, or mostly visible. We looked at optical coherence topography to see if anatomically we could see this gland. So we used a variety of different techniques in the lab using canine tissue. And then we said one of the things I'm known for in the biophotonics community is for using clinical translation of Raman spectroscopy in elastic scattering, for those of you who need to think back in your physics textbook. So I said, okay, let's try Raman spectroscopy. It's kind of a complicated technique, but let's try it. It's weak, but let's try it. Well, every time we put the fiber optic probe, we used a 785 nanometer excitation light, the detector would saturate. From the thyroid, we got a signal, but we had to reduce the integration time from 3 seconds to 3 milliseconds to be able to see any detectable Raman signal from the parathyroid gland. So I said, well, maybe there's something funky about dog tissue. I don't work with animal tissue much. So let's look at human tissue. Still saturated. You always, as an experimentalist, you really think, is there stray light coming from somewhere? Is there light leaking? Is there these little LEDs are saturating? Maybe the computer monitor is doing this. Tried everything. The signal's still saturated. So we decided, well, let's go see in patients. Like I said, we have relatively easy access to doing clinical work. So we took the system. It's a portable system, as you can see, of what we build and use. It's very small, a briefcase size. The laser is the blue box in there. The detector is that little box, and everything is computer controlled. Okay? So we said, let's go to the lab to the clinic, get patient consent, and see what we get when we look at thyroid and parathyroid. We did 5 patients, and I had a postdoc in the endocrine surgeon's lab do this study. He did 5 patients blindly and came back and he said, yeah, every time I needed to get Raman from the parathyroid gland, I had to go down to about 3 millisecond integration time. And I stood there and I just said, wait a minute. If that's the case, then it's my background signal that's strong from the parathyroid. Do I really need Raman? I don't. If the signal saturates, that in itself allows me to find and identify the parathyroid gland. So I got rid of the big fancy Raman camera and used a simple ocean optics camera, little fiber-based camera system, and took that in the clinic, and we measured signal from about now more than 150 patients. And we found that the parathyroid gland has this huge signal in the near infrared, excited 785, emission at about 820, compared to the thyroid gland that has about a smaller percentage signal compared to fat, muscle, nerve, and everything else, which is flat. Okay, looking at about 500 milliseconds of integration time. So based on this, we started off, we collected, like I said, I'm just showing you 45 patients because when you take this to a clinical conference, they want histology validation. How do you know you looked at the parathyroid? So we've done about 157, I think I want to say, as of yesterday. And we found in 100% of patients. How often can you say this? In anybody doing research, you can never say anything happens in 100% of the time. In 100% of the patients up till about a month ago, we saw that the parathyroid intensity was significantly greater, between 1.2 to 20 times, and in these 45 patients, it's 11 times, compared to the thyroid gland, and definitely compared to everything else, is way higher. Okay? So we found a signal which was strong in the parathyroid gland. We've done, as I said, many, many patients to show this. Here's a couple of sort of sample cases I want to show. That is to indicate to you that we use the surgeon's confidence level as one level of standard, because if the parathyroid is normal, it's not coming out of the body, which means you don't have histologies to tell you that that is the parathyroid gland. So we have to rely on the surgeon's confidence to tell us where to make the measurements from. So when we do that, here's a case where the surgeon had low to medium confidence with the parathyroid gland, and we agreed The histology said that, and as I said, remember it's 1.2 to 11 times or 20 times greater than the thyroid, so any ratio signal more than 1.2 will tell you that it's the parathyroid gland. That ratio, that's what the PT, parathyroid to thyroid ratio, was 0.23, agreeing with the surgeon's confidence that it is not of the parathyroid gland. On the other hand, we have this patient 4 case, it's not actually 4, but a 4th case here. The surgeon didn't really know what it was. He didn't think it was the parathyroid gland at all, but we measured our signal very convincingly and said, yes, that's the parathyroid gland. He didn't know what it was stuck to the thyroid tissue. He sent it off to histology. We got histology and then told him, it's in fact the parathyroid gland. Again, validating this approach of what we're talking about. Now, the thing for those who know anything about biological fluorescence will tell you there's no known biological fluorophore at 800 nanometers. Doesn't exist. This is why all these people develop contrast agents and dyes in the near infrared, because biological tissue has very little or no autofluorescence at this wavelength. But I am telling you that there is in fact autofluorescence in certain tissues that is pretty strong, you know? So we did a variety of different studies, something that is present a lot in the parathyroid, in very small quantities in the thyroid gland, and not present in fat and muscle and so on. And as we've gone through a bunch of molecular biology studies, I'm not a molecular biologist, so I won't go into the details of it. I'm happy to share if you want. But through those studies, as well as we've arrived at the conclusion that this signal is coming from the secretory granules, little parts of a cell that produces different hormones and stuff like that, that have very strong signal. This is where the signal is coming from. That conclusion comes from electron microscopy. It's about 426 nanometers in its diameter. What is really interesting is that the adrenal gland has the most known to be the most abundant in secretory granules. And then in fact, we look at the adrenal gland under fluorescent microscope. The dark signal is telling you that it's very brightly fluorescent. The adrenal gland is indeed brightly fluorescent as well. Okay? Exactly what in the secretory granules is biochemically causing this signal, I have no idea. But it works 100% of the time. So we've licensed this technology to a company named Anisys Instruments. They are building a probe-based, a fiber optic point-based system for using this. It does require a trained operator, although the way they have designed their system, you may not. But what the ideal solution would be if I could image it, so the surgeon could see what is glowing, so he knows to leave that alone or take it out. So for the next generation of that, we've actually built 3 different iterations, and actually a 4th one that I'm not showing here, that can do this near-infrared imaging. That's the parathyroid, the darker colored one. That's the thyroid tissue, just pieces of tissue in a petri dish. And here's what it looks like in a patient. Okay? The bright pink spot is the parathyroid gland right there. It definitely glows. I don't know how else to put it. Okay? So this clinical testing for the Anisys prototype is currently in front of the FDA for class determination. We've tested a variety of these things. We have an imaging prototype now that we're currently testing in the clinic, in the operating room, while we continue to evaluate where the signal is coming from. So that's an example of making an impact and a difference in a clinical setting by finding the right solution to this problem of identifying or doing anatomical guidance. That puts me roughly at, I started about 20 minutes ago, so 20 minutes into the talk. I'll try not to go far too long beyond my 12 o'clock original time limit. Adela likes to talk. I can say that, she's a friend. So there are a variety of different things that we have going on in the lab, where in each case we have developed a technique or a combination of techniques based on what is needed for that medical problem. So I pretty much study the clinical problem inside out, just like a surgeon would. My PhD, for example, was on doing cervical cancer detection. I could go and detect and diagnose a patient with cervical cancer just as well as a clinician could, because I've really embedded myself in learning that technique, what goes on in that care. So while we talk about, so I was, one of the projects, one of my first projects when I came to Vanderbilt University was actually to develop a technique that combines fluorescence and diffuse reflectance for brain tumor demarcation intraoperatively. So I was working with the neurosurgical resident at that time, the chief neuro resident at that time, and he was doing the surgery, and he was saying, well, you know, I have to wake this patient up. It was a 12-year-old patient, that's all I remember, who had brain tumor in a very sensitive part of the brain where there was a lot of motor function, speech function. So he had to wake that patient up partly, touch different parts with an electrode to identify the different sensitive regions so he could make sure he could remove the tumor without compromising this 12-year-old's function. And he looked at me and he said, Anita, wouldn't it be great if you could just make all these functionally active regions light up for me so that I don't have to worry about using this little electrode and identifying all these different regions? So I said, interesting thought. So that night, actually, he and I went out for drinks. And as drinks will do to you, you start asking all these weird questions. And while we were still trying to figure out how to make electrical activity light up, and there's a lot of research now that does that, we started asking the question, I wonder if you could use a laser to actually activate neurons. So cause an action potential to propagation in a nerve. That's all you need to know in terms of biology. Okay? So that's sort of the fundamental premise of my tangent that I'm going to take, because a lot of it has to do with lasers and laser development in that area. So is it possible to induce electrical activity with light? Okay? So here is the first 4 years worth of research showing in a simple thing. If you could start the video. Okay, that's the one thing this will not do for me. So what you see is a fiber optic probe. Oops, crap, sorry. You have to do it again, I think. Push the wrong button, kind of like you did. Okay, so fiber optic probe is delivering, in this case, actually a HOMU-MIAG laser light using energies that are significant, very, very much below the ablation threshold. And I'm just moving it across the sciatic nerve of a rat. The main branch point is there. I'm going to rest my elbow so I don't shiver. Rat sciatic nerve with 3 branches that innervate a bunch of muscles. And as I go, what you will find is I can make different muscles twitch. So action potential is propagating across just with this laser light. There's no electrodes. You can see that. There's nothing electrical over there. I can activate, make this to go upward to do flexion, or go downward. Sorry, this is flexion, this is contraction. And make individual toes twitch, individual muscles twitch, and essentially show that you can use pulsed infrared light to activate neurons. Okay. So based on this discovery that we did, so that after that drink, the very next day, we went to the lab and we tried it on a rat because he was doing some nerve welding experiments. So we had an animal protocol to expose the nerve. And we shined a particular laser light in the infrared. And the leg twitched. I said, hey, something's happening. So the remaining 4 years led to that video of showing this. And what it is using, we call it infrared neural stimulation, or INS. It's the induction of an action potential or an evoked potential in response to transient deposition of electrical energy. I want to emphasize that. Pulse light briefly exposing it in a short time frame that caused this. We've demonstrated this in a variety of different tissues in vivo. You saw that rat was actually alive. What's part of the end of that video is the rat actually walking around after we've closed him back up, showing that you don't cause any damage to the nerve. But I just, in the interest of time, I want to keep going. I want to make sure that you realize it's not low light therapy. I'm not just shining a low level of light continuously there waiting for something to happen. This is not optogenetics. You've all probably heard a lot of information about optogenetics. This is not transfecting some kind of genetically mediated fluorophore, but something that lights up. This is not light activation of electrical stimulation either. This is light that you're putting into the nerve that causes the nerve to initiate action potential and propagate through the motor nerves. You can also have it go upstream through the sensory nerves as well. The advantages, you can do you heard all about precision from Adela just a few minutes ago. So, or more than a few minutes ago, but you just heard about it. So you can do precision. You can do very selective stimulation so that you can only get one particular muscle group to show up and no signal from the other, whereas electrically, if you were to simulate, you'd see all the muscle groups have signal. This is electrical, this is optical. Electrically, you see both muscle groups twitching or having signal. Optically, you don't. The other big thing you see is this big spike, which is essentially electrical interference. You get artifacts because of the electrodes and the electrical charge, and you know what I'm talking about, whereas optically, you don't. Because you're not putting in any electrical signal to cause this artifact. So we've done histology on survival experiments of these animals. And the middle is when we've used our INS lasers. That's negative control. You can see this is nice and clean. This is when we do intentionally cause damage, and you see lots of stuff going on. Lots of tearing, lots of stuff going on. Okay? So based on this fundamental idea and discovery, we have a whole bunch of different things we're doing with this with INS. So I'll start by just going around this ring here. Using INS, we can do a whole bunch of things in the peripheral nerve, such as doing prosthetic limb interface, stuff like that. We have some work with a collaborator going on looking at cochlea at Northwestern for cochlear implants. He's done a lot of work to show that, actually presenting at Society for Neuroscience, just this going on right now. We found that, well, you know, lasers, you dump a lot of heat there. So we wanted to find a way to use electrical and optical in sort of a tandem way to see if you could reduce the heat load and still get all the benefits of optical. We call that hybrid stimulation, and we have that going on. That's actually being extended to look at things like one of the things we've discovered. You can not only activate a nerve, you can also inhibit a nerve. So pain is when your nerves are going ow, ow, ow. So if you do something that you can stop that from, you can imagine that you could inhibit pain. So we found that you can use this approach to do something like that as well. We have a bunch of device development that was very actively going on till about 2 years ago. So this technology was licensed by AcuLite. I think most of you probably know AcuLite as this infrared laser building company. They were essentially built infrared lasers for countermeasures. They got bought over by Lockheed Martin. So it became Lockheed Martin AcuLite. And when Lockheed Martin bought up, they told us, the medical licensee, that, oh, we're going to keep the medical division. We absolutely want it. Except 2 years ago, they decided, well, we're going to get rid of our medical division. So they gave us back our license and a decent amount of money, but we're back on the drawing board in terms of the device development. We've got the lasers we developed with AcuLite. We have about 7 of them, but they can't make those anymore, obviously. And we're still back at the drawing board. So for those who are laser manufacturers, we can talk. And then, the thing is, you go, okay, why does this work, right? So that's where actually we've been working with Bob Thomas and his AFRL team for doing some modeling work on looking at the biophysical mechanisms. We've done experiments to show that physically it's a delta T, it's a temperature gradient effect. But how that temperature change transduces itself to an electrical potential is not something we fully understand yet. We've done a lot of experiments, and we have some funding from the Air Force to develop that whole idea. I've been personally interested in looking at the brain, so we've done a lot of work and published a lot of papers on doing this in the brain. We can also use this in the brain and cause activity there. So a lot of work going in this area. So I just wanted to show this is sort of the classic translation project. We actually started this project, that first experiment we did after having those drinks was using a free electron laser. So Vanderbilt was one of the 5 centers funded from the medical free electron laser program that had an FEL that went from 2 to 10 microns. And that's the laser we used to show feasibility of doing INS. So from there we found the wavelength followed the water absorption, inverse of the water absorption curve. And so we settled on 2.1 because we had a clinical Homu-Myag laser that we could take into the clinic as well if we needed to. So we found we could stimulate very reliably using the Homu-Myag, which led to the Lockheed Martin AcuLite Capella lasers. That's what we call them, the optical stimulators, who took this defense technology to build this box for us. So we have a whole bunch of people working all over the place on a variety of different things using this technique, making strides in various ways and directions. Myself, I like to translate things into people. That's my goal. When I come up with anything, I want to know what it can do for people. So we actually did a study in patients who were undergoing dorsal rhizotomy. This is where for patients who have cerebral palsy, so these are little kids who have cerebral palsy, who have uncontrolled tremor, movement of their motor responses, who are so extreme that they can't function. So they will go into surgery where the surgeon will go and just cut off a few of the rootlets at the spine, the nerve rootlets that are coming out, just cut a few off at random based on what he thinks. You'll look at how many of them are hyperactive and you'll just cut a few so that they can live a better life. There's no beyond the logic to it. But what they do is because they cut it, they can also cut a piece of it and give me a piece to histology to make sure that I'm not causing any damage to the nerve with my laser. So we've done 9 patients, and the paper just came out in Neurophotonics, I think a couple of months ago, to demonstrate that we just use the clinical homemiag, which is approved to use in the clinic in the Children's Hospital, using these parameters. And we've done 10 cases to date to show that, and I'll just show you a recording. So this is the right leg versus the left leg electrical recording, okay? And this is what happens when you do optical. What you see is when you stimulate the one particular rootlet electrically in the left, all of them go nuts, okay? Whereas optically, only one muscle group activates. That's the precision in what you could do. So you can be very precise as you cut off those that are doing explicit things by doing this surgery. We've done this on about 10 patients to show that it's safe. And histology we've done as well and shown that there is essentially a probit curve that you can get out of this, and we can get some safety threshold that gives you what kind of irradiance or radiant exposures we need to be able to do this procedure. So, in summary, we have developed a robust, portable, small optical neural stimulator that we've actually, in the research phase, it's got a variable pulse duration and repetition rate. There's tons of papers on what all those effects are. I'm not going to go into that. It's close to lunchtime, so I'm going to wrap up. I've shown a feasibility of doing this with high spatial specificity and no stimulation artifacts. We've done this in cells as well, just so for your interest's sake. We've done this and done it for detected GABAergic current. Using this approach, we know we can use stimulation thresholds significantly well below ablation thresholds to get a safe way of doing this. So in terms of mechanism, we know that the effect is mostly penetration depth is important, and the effect is mostly photothermal. The biological mechanism is a work in progress. So I gave you 2 examples of ways of using light, very different examples, just to get a sense for the variety of different things we can do with lasers. One of the big things that we struggle with, actually there are 2 things we struggle with, and I'm going to bring up the second thing just because Bob is in the room. First thing is that how do you figure out when your technique is good enough? In the case of the parathyroid, we were lucky. It was 100%, right? And they actually don't do histology. They still wanted us to do histology. We were able to show that in a subset to show that it was indeed the parathyroid gland, and we were able to show we were good enough. But in some places, in some situations, histology is not good enough. Gold standard is not good enough. Then how do you show yourself to be still worth it and worth the effort to move forward? The other thing that's not on this list is the laser energies you need to do some of these things for optical detection. The ANSI laser safety standard is great, but it's for exposure in your skin and your eye. Not very helpful for those of us who are developing techniques to go in here or inside the body, right? And so especially when you do Raman, which is one of the techniques I do, you need more than what the safety standard asks for. And so that's another challenge in technology development that's clinically and commercially translatable. Those are challenges that we have to face as we develop this. We've been lucky in a couple of areas to do this in a very targeted way. The other side of the thing I want to mention is sometimes optics and light is not the answer. This is why doing the problem-based approach to us is really valuable, because sometimes you can't quite solve that problem using light. Just adding more and more techniques, I call it omnimodal approach. A lot of people do multimodal approaches to things, especially the biological, because any one technique is not quite good enough. I'm not a big fan of that. I say, okay, you can combine 2 techniques. Sometimes that makes sense when they give you very different pieces of information. But just adding 2, 3, 4, 5 is sometimes not quite the answer for success. And sometimes optical solution is maybe not the right solution, and that's okay. There's plenty of problems there to solve. With that, I'd like to acknowledge my funding sources, and Air Force is not on that list because I changed my slides in the last minute. I should add that to that list. The students and the clinicians who worked with me on the parathyroid project, the collaborators and people who worked with me on the nerve stimulation project. I can't do any of the research I do without the clinical staff supporting me, and that's my email address. You go to the BME department at Vanderbilt University and look for the person with the longest name in faculty. That's me, okay? Really easy to find. Picture of the whole, all the students in the Biophotonics Center, Vanderbilt, and the FEL building. Thank you.
Thanks very much. That was a wonderful talk, and I'm sure, especially out of the last few slides, quite a few of us can learn something for what we're doing, right? So we'll reconvene at 1:30 after lunch. There's, I think, lots of options